Good afternoon, everyone, and welcome to Aduhelm and Beyond, solutions to tackle high-cost specialty drugs and preserve patient-centered innovation. I'm Cece Connolly, President and CEO of the Alliance of Community Health Plans here in Sauga, Washington, D.C. As many of you know, ACHP represents the nation's top-performing health plans that together work to improve affordability and outcomes across the U.S. health system. And since our member companies are provider aligned, they have the fullest picture of how healthcare costs shift throughout the system. Nowhere is that more evident today than when it comes to prescription drugs. As payers and providers, there are many tools we use to contain costs, but those tools are limited in what is clearly a failed prescription drug market, which gets to the heart of the concern over products such as Aduhelm and a host of drugs that come at a very high price tag and, in some instances, little proven effectiveness. Many of these medications are deemed specialty drugs, even though the definition and context of that, which you will be hearing shortly, is open to interpretation. If left unchecked and absent government action, prescription drug costs will continue to explode. Here's why we are so concerned. If you take a look at this infographic, you can see that the number of Americans who take a specialty drug is increasing. In 2019, about 4% of Americans were prescribed at least one specialty drug. That was a 6 percentage point increase from just a few years earlier. While that's still a relatively low number, they are nevertheless playing an outsized role in driving up healthcare spending. Consider this. Last year alone, specialty drugs accounted for more than half, 53%, of drug spending, and that is double the number from just a decade ago. So to be clear, the data shows that a relatively small number of patients and products are having an outsized impact on overall spending. And no surprise, those numbers are only going to go up over time. Now, like most everything in healthcare, the factors driving this trend are complex. But one thing is perfectly clear. Drug companies continue to game what few rules there are in place with little regard for the patient's budget and even less regard for the federal budget. There's no better time to fix drug pricing problem than the present. Here in Washington, there is actually some momentum to finally put reasonable restraints on longstanding practices that have tipped the balance in Big Pharma's favor. Legislative policies that would allow the federal government to negotiate on drug prices or put restrictions on initial pricing are suddenly back in play. And if approved, these tools would go a long way in keeping coverage and care affordable. Short of congressional action, our ACHP member companies across the U.S. will continue to do their best to get patients the treatments they need at an affordable price. Today, we have assembled a great group of experts who will talk a little bit more about what they're seeing and doing on the ground. And we have a terrific moderator to wrangle them all in this conversation today. And so with that, I'm pleased to quickly introduce first Cronus Manolis. He's the Senior Vice President of Pharmacy Services at UPMC's Insurance Service Division, where he also serves as the Chief Pharmacy Officer. In a career that has spanned decades, he has also led one of the first specialty pharmacies back in the 1990s. Brent Eberly, many of you may recognize because he has testified on Capitol Hill on topics around drug pricing. He's Senior Vice President and Chief Pharmacy Officer at Navitus, which in and of itself is a pretty unique alternative to some of the traditional pharmacy benefit manager companies that we see out there today. And finally, Polly Webster is a Senior Policy Advisor for Kaiser Foundation Health Plan here in Washington, D.C. And again, many of you, I'm sure, know Polly from her work on Capitol Hill, where she served with Congresswoman Diana DeGette and also on the influential Senate Finance Committee. In charge of harnessing all of this brain power today is Sarah Carlin Smith. Sarah's a senior writer at the Pink Sheet, which is a national publication. We like to think of it as the Bible on pharmaceutical coverage. She's a seasoned healthcare reporter covering everything from FDA to CMS with a special focus on drugs and the pharmaceutical industry. You may also recognize her byline from her days at Politico. And so before I turn the conversation over to Sarah, I'm just going to ask that all of you please jump right into that chat box and get going with your great questions and comments and dialogue so that this can be a really interactive session. And with that, Sarah, it's all yours.
Hi, everybody. It's great to be here. Thank you, Cece. And like she mentioned, we want to take audience questions as well as the ones I have prepared today for the panelists. So get those in so I can intersperse those throughout. I wanted to start off by kind of setting the stage here for everybody. Cece sort of alluded to this. There's no technical standard definition of what a specialty drug is. So I was hoping each of you could go through and say kind of how you define it within your role and your part of the industry. And I think we'll just go in alphabetical order perhaps and start with Brent, if that's okay.
Oh, that sounds great. It's a tricky definition because I think it can be very situationally dependent. And what I mean by that is there's one definition that may be used for contract terms. There's another definition that may be used when setting up a plan design, is that what drugs are mandatory through the specialty pharmacy, which drugs can be purchased through retail. It can also be what CMS defines, and CMS defines it as a pure dollar value. I think $780 is the cutoff for 2022. And so knowing when we look at it internally, we have to be very clear about what situation are we talking about and why are we talking about it in that context. From a clinical management perspective, we really don't get too hung up on the specific definition. We look at that product, look at the uniquenesses of it, both from an administration perspective, the clinical complexity perspective, and the cost perspective. And then we will make that management decision, whether maybe it's a mandatory specialty drug or not. We don't focus too much on that. But I guess to sum up, what I would say is we have to be very clear when we're talking with our clients, when we're talking internally, in what context is the definition important, because it does flex depending on the scenario.
I'm going to jump over to Cronus and let you go next.
Yeah, no, I think Brent hit it right. I would just add a few things. You know, in the old days, I came from specialty pharmacy. We kind of had an idea that complex disease, complex patient, maybe complex shipping, et cetera. But over time, that definition has become, to use the word, situational. And I think it's a challenge that what we try to do is reduce it down to, is that a drug that particular patient with that disease would be better served at a retail pharmacy, where they talk to their pharmacist about a lot of their conditions, or at a specialty pharmacy? And I think that's where the lines have blurred over time. I think pharma has used the definition to their advantage, because when you can label something as specialty, it gives you the ability to price it beyond the typical brand traditional drug. And I think that's where, you know, we started to get into these arguments about the definition. And again, but if you go back to keep it simple, if it's a cholesterol drug, you know, generally the patient's getting their cardiovascular diseases at that pharmacy or at that mail order pharmacy. Maybe that's where that drug belongs. Sure, it may have been a biologic, et cetera, but it's still, you know, it's still a drug that probably should be in the traditional framework. And migraine drugs, we don't consider those specialty drugs because, you know, there's nothing special about them from a disease perspective and the high touch needs of the patient. And I think I'll just add one more thing. I think it can backfire if you price things at a specialty drug in the Medicare benefit. You know, the Medicare benefit can be really tough on specialty drugs. It's generally a high cost share, and most plans are going to use that because because everybody else is. And so it really harms access. So I think we've done a good job as payers to educate pharma to say, beware of those pitfalls. Don't call something specialty just to be able to give you a specialty price tag advantage. But let's go back to the spirit of what specialty drugs are.
And Polly, you're up last.
Thanks so much, Sarah, and thanks so much to ACHP for having me on the panel today. I think that Kaiser Permanente's lens on this is really similar to what our colleagues just mentioned. We're grappling with a lot of the same ambiguities with respect to what constitutes a specialty drug. Our approach, we generally look at a wide array of different factors to make an assessment internally about whether we would categorize something as specialty. Those might include high cost. Are there unusual steps with respect to prescribing or managing or procuring or dispensing the drug? Various different safety issues that might require a high touch management approach, as well as how the drug is, if it's subject to requirements like limited distribution or centralized dispensing and things along those lines. So we don't really look at it with respect to what treatment venue the drug is in. We think outpatient, inpatient, things in the medical office or infusion centers, all of those things could potentially be specialty drugs, but rather we sort of have a factors-based approach to thinking about whether or not something should be in that category. But again, the struggles with the definition are very real for us, as they seem to be across the entire healthcare system.
And I think I'd just add quickly, I think what we're going to quickly see is there's going to be multiple definitions of specialty. Cronus kind of described what we've been kind of terming some of those specialty light products. So the PCSK9s, the migraine medications. And then we've got the normal specialty meds. And then we've got these extreme ones that are the multi-million-dollar therapies. And then we could be rolling into a fourth category with maybe biosimilars being treated separately. So as much as we've struggled with a generic definition, that's probably a bad word, but a general definition of specialty, I think we're going to end up with these sub definitions, and those sub definitions are going to start to drive things like plan design and where can you access those medications.
One thing when I was refreshing myself on this topic ahead of this panel I was reading about was the recent change Medicare is going to allow for 2022, which is to have a sort of dual specialty tier or create like a preferred specialty tier. Does anyone think that this is going to kind of change the game in any way, or how products are priced or accessed by patients?
Go ahead, Cronus.
No, I think it adds confusion. I think there can be benefits. We've just got to digest it, but I think it does add confusion. What we've always done is have one specialty tier and use our policies to manage the preferred and non-preferred products within that. Creating a second specialty tier is another option. But we've already got how many tiers in our Medicare Advantage benefit right now? It's we've got 0 tiers and everything else, and I think what's happened is people blur the lines about what's a brand, what's a generic, which further complicates things. The only thing I'll add is that we are going to start to see biosimilars, and we're going to start to see more generic specialty drugs, and we have to have incentives for the member to be able to buy those products and get a reduced copay. And I think that's one of the angles that CMS is trying to go for. And from that lens, yeah, while they're still expensive drugs, we should have a differential copay tier on those drugs.
Brent, did you have anything else to add, or did he take all
No,
your thoughts?
I think he covered it really well. I think it adds a lot of complexity, but I think it's going to be something that's needed or something that's going to become more common, because we have to create incentives for the generic and lower cost specialty items. And if we end up with these different buckets of specialty drugs, I think we could quickly see multiple different types of specialty tiers, not too dissimilar to what we see in the kind of non-specialty world, where it's very common to have a generic tier, a preferred tier, and a non-preferred tier. I think there's going to be some adaptation of that model to it's going to become more common to adapt that model to specialty medications.
I wanted to talk more broadly about the benefit design, and I don't know, Polly, if you want to go first, but can you guys talk a little bit about what is the impact of kind of this small percentage of utilization on how prescription benefits end up being designed, and also maybe how companies kind of price their products because of the way Medicare kind of defines and the benefit and specialty drugs?
Sure. Yeah, I can jump in first on that question. So just as a little context, Kaiser Permanente is the largest private integrated healthcare delivery system in the United States. And so our perspective and approach on these types of benefits questions is often a little bit distinct from, I guess, what you could say, if there is an industry standard, sort of the industry standard way of doing things, since we're such a strange animal. Just to give a little more context, we do our price negotiation with manufacturers and wholesalers in-house, as well as all of our formulary development in-house, instead of outsourcing that to sort of a third-party PBM type of entity. And our formulary design process is very evidence-driven. Our Permanente medical group physicians have a really close partnership and collaboration with our clinical pharmacists, and they work together in each of our regions to develop a really evidence-based formulary and assess all of the clinical trial information and other forms of evidence that are available on a particular drug. And then once those sort of formulary and treatment guideline decisions are made, we say to the contracting team, go forth and get the contract. So it might be kind of the process that the rest of the industry is using, but in reverse in some types of ways. So with respect to specialty, I think we're really challenged from both a benefit design and a price negotiation perspective, because for so many of these drugs, there's very, very limited competition, if any, in the marketplace, which of course, impacts us from a benefit design perspective, because in a lot of cases, a particular specialty drug might be the only option that a patient with a certain condition has. And when that's the case, there's not a lot of opportunity to manage cost or use, utilization management type of tools because, the patient has a medical need for that product. I think we're also very challenged from a benefit design as well as a contract negotiation perspective, because many of these drugs are increasingly coming to market through expedited pathways at FDA, where limited evidence is required on the pre-market side. And a lot of that product evaluation is getting pushed into post-market. So since our process is so evidence-driven, having those gaps in evidence when a product initially comes to market, and then often for many years beyond then, is very challenging. And I think what's going on with ADUHELM is sort of the poster child now for this issue, though we've been experiencing it for many, many years, particularly in the area of oncology, but also in other therapeutic areas where you have these types of challenges. So even though specialty is a small percentage of utilization, I think that our numbers pretty closely reflect the numbers that CC put up at the beginning of this presentation. It's a very difficult category, I guess you could say, or bucket of drugs to manage from a cost perspective. And it also challenges our physicians on the ground in a lot of cases and folks providing frontline care, because it's hard to develop treatment guidelines and educate patients about these products when the evidence on the pre-market side is often so limited. And of course, they also tend to be very, very high cost. So even though it's a sliver of utilization in a lot of cases, again, depending on what definition of specialty drug you use, it's a very disproportionate share of spending. And so I think as pipelines continue to trend towards specialty and orphan drugs, we're going to continue to see these challenges grow, not just for KP, but I imagine for all payers and purchasers across the healthcare industry.
You sort of alluded to some of the challenges you have in Medicare. CC also teed up a little bit that there's a political debate going on Capitol Hill now around whether to address drug pricing and give the government more power to tackle the cost of drugs in Medicare, as well as just general rethinking of the Medicare Part B benefit design. I was curious, from your guys' perspective, what, if any, assistance would you like to see from the federal government around this area of specialty drugs? And it could be something that would have to come from Congress or something that could be more CMS specific.
I can jump in. I mean, I think that I think Paulie defined the benefit challenges pretty succinctly, but I think the big hole that we have in Medicare, and I've been to CMS with ACHP talking about this, is around mandatory specialty pharmacy use. So if you believe in the concept of specialty pharmacy, and that provides a differentiated care model, a whole person care model that we'll talk a little bit about, then to me, why would you let users of specialty drugs go to any pharmacy anywhere? So full disclosure, I'm an old retail pharmacist guy. I have nothing against the capabilities, but these are drugs. These are highly specialized drugs. And so there's a reason why plans to this day require a 30-day benefit in specialty drug. It's not, it's not because we just want to, it's a cost thing. We want the patient checking in with the pharmacy every month. These are complex diseases. We need to take a whole person view of the patient. And yet we have an any willing provider provision in Medicare that allows any pharmacy to dispense a specialty drug, provided they can get the drug. And there's a lot of them that can't. But do you think, I'll ask the rhetorical question with all due respect, do you think the same disease specialty and high touch service can come from a local drugstore than it can from a specialty pharmacy that's been credentialed and has all of those resources? And when I say resources, I'm talking about resources like that address social determinants, social workers, nurses designed in that specialty, the ability to capture everything that's happening with that patient. So we've been arguing this for a lot of years, and I think that health plans get a bad rap. Maybe we're confused with PBMs that own our own, and even if a lot of health plans own their own specialty pharmacy, we do. We believe in a better clinical model for those patients, and I don't think it's a takeaway. These are all drugs that generally come by mail. And I think that would be something that I don't think it may reduce costs. It should, but it should really improve the quality of care. And that's something I think CMS owes to itself to look at.
Your response actually was sort of teed up in some ways by a question in our chat. An audience member asked, do you think CMS will ever define what a specialty pharmacy is in relation to this conversation, or because in the past they've declined to do that? Seems like you're sort of saying that might be important.
Well, I think the pharmacies define themselves as specialty. They have to contract with PBMs to provide specialty drugs. So as long as we have that identifier, why couldn't we, make the use of a category of drugs or all, because that's the other thing, we got to define the drugs, and we've just spent 10 minutes saying how crazy it is, but we can get to that answer. And then we allow it only to go to specialty pharmacy. And I think there's something to be said for tomorrow's specialty pharmacy, which also has to reinvent itself to be able to look beyond just volume of drugs, expensive drugs, but really whole person care. So I think those are operational issues we can get through.
And I think this,
sorry, go ahead,
on the CMS definition of a specialty pharmacy, there are very strong specialty pharmacy quality accreditations that facilities, pharmacies can take, whether that be URAC, ACHP, NCQA is starting to look at that as well. So I think that it's pretty, while any pharmacy can really just call themselves that because there isn't separate licensing, I think CMS could very easily reference some of the quality accreditations so that we can make sure that that a specialty pharmacy is truly providing the services that were mentioned.
Brent or Pai, I also wanted to give you guys a chance if you want to answer that sort of broader question of what, if anything, you want to see from Washington at the moment that you think might help kind of improve your work managing specialty drugs?
Oh, Polly, go ahead. I'll let you.
Sure. Yeah. I mean, I think that again, it's really challenging because we've certainly appreciated lawmakers' continued attention to things like anti-competitive abuses, because this is a space where competition is very limited. Many of these drugs, of course, have things like patent thickets. We've seen REMS abuses, and we were really appreciative of Congress passing the CREATES Act to help resolve some of those issues, like the withholding of samples from generic manufacturers to help increase competition on certain drugs where manufacturers were engaging in that type of behavior. So I think continued attention in that space could potentially be helpful, but there's also a reality that even if some of the other anti-competitive abuse issues were addressed, some of these drugs just are not in therapeutic areas that are ripe for competition in general. Like there are so many layered challenges, both from a legal and regulatory perspective to entering these markets, but also just the nature of the markets themselves are often small and have various other barriers to entry. And so I think that our industry is now in a position where, as policymakers are recognizing these market failures and the really negative impact that they have on patients and their families with respect to affordability, they are turning toward more intervention directly on drug prices instead of trying to fix the market. And I think conceptually, Kaiser Permanente does feel like the prescription drug market, particularly because of patents, but also because of other overlapping laws and regulations like FDA rules, things like various different coverage requirements that you see in Medicare, does feel like the prescription drug market presents a lot of very unique issues that sort of exacerbate these types of dysfunctions and lead to, more ever higher prices. We do feel like some level of intervention may be appropriate, but because of how sweeping some of these changes are, the devil is really going to be in the details. And so I think from our lens, we would appreciate the help in being able to access government negotiated pricing if it ever comes to that point where Congress is moving that legislation potentially in the reconciliation package. But at the same time, we'd be paying very close attention and would want to be involved in the design process whenever that moves to an implementation phase, just because, as we all know, this market is incredibly complex. So very long answer to your short question, but it's a complicated issue and an interesting time in this policy space for sure.
The one area I maybe add, and it's not necessarily a Medicare issue specifically, but is really around copay cards and manufacturer coupons and how those really disrupt the market from the normal. Those cards completely isolate members from really the true cost, even the copay costs. And it allows manufacturers to continue to increase prices because the members are somewhat, or in a lot of ways, completely isolated from that. I think with how it's run today, it also puts plan sponsors in this difficult position to have to continue to increase the maximum out of pockets and increase the coinsurance because they realize that their members aren't really paying with the coupons, aren't really paying those rates. And by having what I'll say is more reasonable copays, they are probably subsidizing those plans that have higher copays and higher coinsurances. So what I would like to see is some standardization around how these cards work, what are the limits, and some standardizations of them, because any brand, and it's not unique to specialty, any brand product has these today. And I think the first thing a lot of people do once they are prescribed something, they will Google it, and the coupon is generally the first thing that pops up. So I think there needs to be much more awareness and much more standardization of how these coupon programs work, what portion of that is a member benefit, what portion of that should be a plan benefit, and how that all fits together, because it's created kind of this ripple effect in the market, and it's adding costs that don't need to be there.
One of the questions that came in was about whether CMS should eliminate or limit copay coupon use is that something you guys would support in terms of just kind of across the board permitting it? Obviously, there are already sort of limitations to some degree in Medicare as to how the coupons work, but they sort of proliferate through sort of these private foundations, even though companies can't directly offer them.
I think we've gone well beyond the intentions of the copay card. There's a new schema invented almost every day, and I think Brent brought up one of the top 2 or 3 issues that we're dealing with today. There's a lot of people that want to disintermediate your pharmacy benefit, and from my perspective, as someone who filled prescriptions a long time ago, having the data in one pool is still the most powerful clinical tool that we have. It's so underrated because we've become so automatic in our processes. When people start to pay cash for their prescriptions and plans lose visibility into them, that means physicians lose visibility into them. You start to get a lot of fragmentation. And we don't keep track of these statistics, but as someone who worked in a high volume pharmacy knows, that information is invaluable. And we've learned, the pharmacy profession has learned to be able to do their job, but also respect that information. The minute we start, the same with the $4 generics that happened 10 years ago. We just started to fragment the pharmacy benefit. It's through a lot of these coupons. And then the PBMs cannot do their jobs, and then everybody is kind of getting misinformation. And so it's a bigger issue, but I think that you have to look at the broader scope when you think about copay cards and saying, what's it doing to the information flow, and what silos are we creating? And Sarah, I have one more. If you ask the question, I'll be very fast. I'm very passionate about this. If I were to ask CMS one thing, I think Cece said it best in her opening. We're all provider aligned plans. We're clinically oriented plans. Yet to this day, and I've been here 15 years at UPMC with a Medicare benefit, we are not allowed to manage clinically as well as we can in our commercial and our Medicaid businesses. And I know there's a long history of abuses or whatever those reasons are. I won't use the clinical classes of concern because it's too indicting in one area. It's just in general. When we have specialty drugs or any drug, our job is to make sure, Polly talked a lot about how there's no competition in these categories. Then we have one job, is to make sure that we get the appropriate patient, that we manage it clinically according to collaboration with our physicians. And literally, I don't know, 20, 30% of the time, our policy has to be watered down for CMS. And we don't understand that because it's done in collaboration with our specialists. It's not a barrier. It's just really good medicine. So we know the demographics of how many people we're going to turn into Medicare every day. And we know there's a limited budget. I'm not sure I understand why we're not managing as best we can.
I wanted to go back to before you talked about that issue, you brought up data and what data you have access to. I was wondering, maybe, I don't know, Brent, if you want to weigh in, but could you also talk a little bit about how data is used sort of to manage patients on specialty drugs and kind of contain their spend or do sort of like wraparound care as well?
Yeah, absolutely. I mean, data analytics is key across, well, in healthcare in general, in pharmacy, and then when you get to the subset of specialty pharmacy. Data analytics is going to be key to identifying any waste, and that could be from dose optimization to removing duplicate therapy. From a clinical perspective, how do we make sure that that there's adherence, that we're getting the outcomes, and even there's a lot to be learned even from prior authorization data. What's being approved, what's being requested, what's being denied, why is it being denied? And all of that data helps us to kind of evolve our thinking of that product and have an understanding of how our prescribers are viewing it, and to be able to identify outliers. So if there's a specific either off-label or fringe indication, who is requesting it, why are they requesting it? And then The other area where I think it's starting to grow and is going to provide huge benefits is we talk a lot about specialty pharmacy from the kind of the PBM side or the pharmacy benefit, but there's so much specialty utilization on the medical benefit. And historically, there's lacked good data analytics in that space. So to be able to apply all of those things that I just mentioned to the medical benefit and then introduce uniquenesses around site of care differences and billing differences, there's a lot that can be done with data analytics. And I think specialty is the perfect example where you can get a ton of value by investing in that data analytics.
Polly or Cronus, do you want to weigh in on the role of data?
Well, sure. I mean, it's a little bit different for KP again, since we're an integrated system. Instead of having a lot of different disaggregated parts across the healthcare system, all or most of this is happening within the Kaiser Permanente entity. So, you know, we are obviously tracking our own data across the different components of our system with respect to specialty drug utilization, what type of members are using it, prescriber patterns amongst our physicians and other clinicians, things along those lines. But I think that for us, the key is really a lot more upstream. And again, to kind of pivot back to the evidence, you know, it all really starts for us in that review of the evidence, the discussions that happen at our P&T committee level, but also the discussions that are happening among specialists in our system who are working to put together treatment guidelines. Because for our physicians, you know, our treatment guidelines are developed by their peers. So there's a lot of trust in the treatment guidelines as well as the formularies that our system comes up with, because they're peer developed, and folks can talk to their colleagues and share experiences with different patients, and we can use the data within our system and through kind of a feedback loop to help inform you know, future decisions along those lines as we see how drugs perform in different types of patients. But certainly, I mean, the data is critical. We know manufacturers obviously also have a lot of interest in this type of data as well, especially again, as you know, their responsibilities are pushed more into the post-market side for product evaluation with a lot of these types of drug products. But certainly it's really important. And for our system, you know, we're especially focused on if there are ways to sort of generate more real world evidence about these products that we can use to help inform treatment guidelines in the future and deliver better quality of care for our members.
Yeah, and I'll just add, Sarah, I mean, I agree with everything that's been said. I think if we're ever going to fulfill the expectation of what true specialty pharmacy is from a clinical differentiation or an extension of the care team, data is critical. We need to have a bi-directional data flow. You know, when I worked in specialty pharmacy in the 90s, we discovered something when we interviewed a patient. We faxed it to the specialist. They put it in their chart. I don't know that it ever saw the light of day, right? But now we create a care coordination bi-directional flow of data discovery, and we can send notes to the specialty pharmacy to talk about the different barriers that we discovered, or, you know, do they have access to specialists, whatever that is. And that's a two-way street. When they you know, they do a great job with drug. When it's something out of their purview, send it back to the health plan where we have community resources, we have internal resources that may be able to help that patient. And I think that's the promise of data along so many different continuums, but that's the one I get excited about. If we're going to hold the specialty pharmacies more accountable and get away from just a drug delivery kind of mechanism.
A couple times in our conversation, biosimilars have come up. I know, having followed the sort of creation and development of this sort of regulatory pathway to allow for, you know, copies essentially of, you know, more complex drugs. It's taken a long time for, you know, the biosimilars to get out there into the marketplace, and we only have one biosimilar really right now that's technically interchangeable, and it's quite new. What role do you guys see biosimilars playing in this conversation and dealing with the costs of high-priced medicine?
I can jump in here quick. I do think it presents an opportunity that has to be maximized. And so as these opportunities come, they are going to produce some cost savings opportunities. And when I say maximize, that could take a number of different forms. And this is where it kind of gets, from my perspective, gets a little tricky. Because with some of the initial ones, what we saw is really the brand manufacturer continuing to discount it at a rate that the brand was still less expensive to the payer than the biosimilar. And it's really hard for a payer to choose a biosimilar if it's again, it's going to increase the cost compared to the brand. On the flip side, I think we saw that, and it also led to this very slow adoption of biosimilar products. Now, that could have been a very unique situation with Remicade and future. I think there was a lot of learnings from that in terms of how that adoption takes place. But I do think plans need to be thinking about what's their philosophy with this. Meaning, are you going to, as a plan, are you going to select the biosimilar irregardless of the cost, even if the brand manufacturer gets more aggressive? Is that a philosophical stance that a plan wants to take? And they need to be thinking about that now, I think, before the situation is in front of them. And then just thinking about, what is your education plan? How are you going to work with prescribers around educating around interchangeability, and not only the providers, but the members as well, so that because this is going to be new, there's going to be a ton of misinformation out. There's going to be lots of different angles that are going to be played. So bringing that right communication message and being organized to get that information out, I think is going to be key to maximizing the opportunity. But there are very few, as we've heard throughout the day, there's very few situations in specialty pharmacy to save significant dollars. Biosimilars present that opportunity, and plans are going to need, or we as a society too, are going to need to take advantage of that opportunity as we see the pipeline, we see not only the new drugs, but all of the new indications for current drugs. We have to take advantage of this.
Yeah, I mean, if you look back, we're coming up on the 10-year anniversary of Lipitor going generic. That was probably a 2-3 year period that they called the patent cliff, and it provided unbelievable relief to the industry, which really kind of facilitated the explosion of specialty drug. You fast forward another 10 years, we are on the we're on the doorstep of transformative therapies, gene therapy, cell therapy, you name it. How are we going to have room for that? We have to maximize biosimilar adoption. There's no way about it. And I tell you, there's competition's good, and that's what we need. But if you asked me, for someone who's been talking to our docs about biosimilars for years, the interchangeability is not the issue. It's the games that people are playing with pricing and the fee schedules of different providers and things like that. I would imagine it becomes much easier in a KP than it does in a mixed environment like it, where we have our own providers and our non-owned. But that's the biggest thing, is how do you ferret out the savings? But make no mistake about it, it's going to have to be like the patent cliff of 2011 all over again. And 2023 is the watershed year. It's Humira, #1 big drug in the world. Everybody's already starting to talk about it, but will we be able to, make it happen? And will we be able to give our member the real benefit? Brent talked about it. A lot of these people are using copay cards today. They don't really feel that copay. How do we make it even better for them? So
I just really quick, I just want to jump on one thing, because I think you raised a huge point. The patent cliff, when that happened 10 years ago, hid all of this stuff that was going on in specialty, where people were seeing either negative or low single-digit pharmacy trends. But it was all of this happening kind of behind the scenes. And then when those savings went away, all of a sudden there was this huge specialty bubble. And I think we have to be careful when this happens and we get this bulk of savings, that we don't let it hide or mask other things that are going on behind the scenes, and really learn from some of those lessons from that patent cliff experience.
Yeah, oh, sorry, go ahead. Sarah.
Go ahead, Holly.
I think that, just to echo the comments that both Kronos and Brent have made, KP is a heavy utilizer of biosimilars. For Zarzio, it's over 95% of our utilization internally. For Inflectra, we're in the upper 80s now, I believe. And I just want to reemphasize what Cronus said, that interchangeability is not always necessary even to convert patients onto a biosimilar product. And what's really critical is what Brent mentioned, which is making sure that the prescribers and clinicians on the ground are educated about how to go through the conversion process. And again, I think a big part of our success at KP is because of our integrated structure. We effectively have ambassadors within our system who educate their colleagues about how to do both new starts on biosimilars, but also converting patients from a reference biologic to a biosimilar product. So just really wanted to reemphasize that point because I think it's very important.
Well, unfortunately, because we had some really good questions in the chat, but we're going to have to wrap this up, and I'm going to throw it back to Julie at ACHP. But thank you all for being here, and obviously the continued sort of questions I'm getting at the end shows how hot a topic this is and how interested everyone is.
Thanks so much, Sarah. Yes, a huge, huge thank you to today's panel, to Cronus, Polly, and Brent for truly demonstrating their expertise in this conversation, for making a complex conversation a little less complex. We, of course, also want to thank Sarah for doing such a fantastic job as a moderator. She's a great follower, so a great person to follow. So we can't wait to see more of her stories coming out on this industry and to follow her reporting there. She did ask a great question earlier, which is, what, if anything, do you want to see from Washington? So I want to direct the audience to the fact that ACHP has some thoughts on that matter. Those thoughts can be found by going to our website, achp.org, and clicking on Issues and Drug Pricing. There you'll find some wonderful resources, including a fact sheet, an op-ed by CC, and of course, a newly released issue brief entitled Lowering Drug Costs Through Transparency and Competition. With that, I will pass it over to my colleague, Matt. But again, a huge thank you to all of our panelists and to all of our attendees today.
Yeah, and I just simply want to echo your thanks to everyone. That was a great conversation. Obviously, as you heard at the very beginning, the timing could not be more perfect right now here in Washington. We're having these conversations both from an advocacy and from a policy perspective. Julie did a good job of directing you all to some of the work, some of the collateral that ACHP has out there on our positionings around some of the drug policies that are in play right now. And I just want to just sort of underscore that our advocacy efforts are aligned with those policies that you'll find online. And that's the work that we're doing and the conversations that we're having on Capitol Hill right now, as many of you are as well. So again, thanks to everyone. I think this is probably a good stopping point. Thank you all for spending your afternoons with us as well as attendees. And again, thanks to the panelists.